Hello students, now we are going to start a series of new lectures on obstetrics and gynecology. In this version 2, we are going to start with the basics again. So, the topic which we are going to discuss today is the anatomy of female reproductive tract. Under anatomy of female reproductive tract, we are going to discuss now about the external genital organs. Guys, please concentrate. What exactly are the external genital organs? The external genital organs are those which are present outside the female body, which means you can see with the naked eye. So the collective term which is used for the external genital organs is nothing but the vulva. So vulva is nothing but the external genitalia in the female, which also includes the perineum. So please concentrate that vulva includes external genital organs plus a perineum in the female. Now what and all the structures which are coming under the vulva? Okay, so please concentrate guys. It's the mons pubis, labia majora, labia minora, a clitoris and vestibule. So all these structures, they are the external genitalia, which is nothing but the vulva. Now let's discuss about the internal genitalia. Under internal genitalia or the internal reproductive organs, the structures are a vagina, uterus, a fallopian tubes and ovaries. So the one important point which I want you to remember is vulva is something external. See, most of the students think that what they can see from the naked eye, what they can see from the outside, it is vagina. No, vagina is something, a fibromuscular tube which is present inside the body. Okay, so after seeing this, let's see all the structures on the image. Now please concentrate guys. See in this image what you can see with your eyes. So this part is nothing but the vulva. Guys, in this vulva, these folds which I am highlighting to you right now, okay, these folds which are present laterally, these folds are known as labia majora. Okay, now medial to the labia majora, these structures which I am highlighting you, okay, these thin folds which are present medially, okay, these folds. So these folds are known as labia minora. So they are labia majora and medially these structures, pink color structures, which are known as labia minora. Now after seeing this, let's see a few more important landmarks which are very much needed to understand the concepts. Guys, please concentrate that this labia minora, they are coming anteriorly and they are fusing over a small nodular structure. Okay, I think you can see this small nodular structure. Okay, so that structure, see this structure is known as a clitoris. Clitoris. So what I am trying to say, over the clitoris, the labia minora, they are fusing anteriorly. So this structure is known as a prepuce. Okay, so prepuce, what exactly is prepuce? The labia minora fusing anteriorly over the clitoris, and in the same way, the same labia minora, it will fuse even inferiorly. Okay, please concentrate here. The same labia minora, it will fuse inferiorly as well as superiorly. The superior structure is called as a prepuce and the inferior structure is called as a frenulum. Okay, this one, frenulum. Okay, so we have seen what exactly is prepuce, clitoris and frenulum. Now if you can see these labia majora, see these thick folds, these labia majora, they are coming posteriorly and even they are fusing here in the midline. So this structure where the labia majora fusing posteriorly, this structure is known as posterior commissure. Okay, so what exactly is posterior commissure, guys? Fusion of labia minora posteriorly. Okay, well and good. Now what you have to call, what should be called where the labia minora are fusing posteriorly. See, the labia minora also fusing posteriorly, right? So this structure where the labia minora are fusing posteriorly, so that should be called as foresheet. Okay, so what exactly is foresheet, guys? Fusion of labia minora posteriorly. Now, after seeing posterior commissure and foresheet, now let's discuss about fossa navicularis. What exactly is this fossa navicularis? Guys, please concentrate. It's a depression between, guys, first of all, if you want to know fossa navicularis, you should also know certain important other landmarks. Guys, here you can see a opening. See, this opening is nothing but the vaginal opening or vaginal introitus. That is the place where the vagina is opening outside. Now, this is introitus. Okay, this is the introitus. The space between introitus and foresheet. Okay, posteriorly this is the foresheet. Okay, so foresheet. So the depression between introitus and foresheet, this structure is called as a fossa. Fossa navicularis. Okay, so what exactly is fossa navicularis? It's a depression between vaginal introitus anteriorly and foresheet posteriorly. So this is what exactly is the fossa navicularis. Now let's discuss about Hart's line. Now if you want to know what exactly is Hart's line, you should see here. Guys, what are these structures? These structures are nothing but the labia minora. We all know. Now labia minora outside, okay, towards the outside, it's nothing but the skin. Okay, so labia minora laterally, okay, laterally, for example, this part, okay, this part laterally, they are lined by stratified squamous epithelium. Which epithelium? It's a keratinized epithelium. Okay, so stratified squamous keratinized epithelium, which is nothing but the skin. But medially towards the inside, here in this area, the labia minora are lined by non-keratinized. Okay, so non-keratinized squamous epithelium. So what is exactly this Hart's line? Hart's line, it's a demarcation point or it's the junctional point where the keratinized epithelium of labia minora, it's getting converted into non-keratinized epithelium, okay, medially. So this junction, this imaginary line, okay, so this point where the keratinized epithelium is getting converted into non-keratinized epithelium, so that point is known as Hart's line. So this is something important. Now after seeing some important landmarks, now let's go further. Guys, before going further, I just want to show you one more landmark. See this thick pad of tissue, okay, here this thick pad of tissue with the hairs and all, that's known as mons pubis. Okay, so mons pubis, we have seen labia majora, labia minora, clitoris, foresheet, posterior commissure. We have seen some important points. After seeing this, now let's discuss about what exactly is a vestibule. Okay, what exactly is a vestibule? Now, guys, vestibule, it's a triangular space, bounded anteriorly by the clitoris. Guys, please concentrate. Anterior border is the clitoris and posterior border is the foresheet, for example here. So a triangular space which lies between clitoris anteriorly and foresheet posteriorly. So this triangular area is known as a vestibule. Why this is important? Why? Because they can ask you what are the structures which are getting opened into the vestibule. So you should know. Now guys, please concentrate here that here is one opening. What is this one opening, guys? It is the opening for the urethra, urethral orifice. Okay, so urethral orifice. Okay, well and good. Now, below the urethral orifice, there is one more opening. You all know that. This is vaginal introitus. Okay, or simply vaginal opening. Now, apart from the urethral opening and vaginal opening, there are certain ducts which are getting opened into this triangular area. So, what are those ducts? Guys, please know for now, there are ducts of Bartholin's gland. Okay, Bartholin's gland ducts. Okay, so Bartholin glands, which are also known as the greater vestibular glands. So two ducts, they are also going to open into the vestibular space. Okay, and see, side to the urethral opening or side to the urethral orifice, which means here, over here in this area. Okay, so there are certain ducts which are getting opened. Now, can I call sites as para? Yes, so para urethral glands. So, ducts of para urethral glands, okay, which are also known as skein glands. So, into the vaginal, into the this vestibular space, okay, into the vestibule, which structures are getting opened, guys? It's the urethral orifice, one structure, vaginal introitus, one opening, and two ducts of paraurethral glands and two ducts of Bartholin glands. So total into the vestibule, 6 openings are there. Okay, so 6 openings are present in the vestibular space. Now after seeing this, let's see a few more important points, guys. Here and then you can expect a one MCQ from this area, guys. Now we are discussing about the homologous structures. What exactly are the homologous structures? Homologous structures are nothing but the similar structures in the male counterpart. For example, labia majora in a female. We have seen that what exactly are the labia majora. So the thick folds. Okay. Now labia majora in a female is homologous to which structure in a male? It is a scrotum. Okay. It's a scrotum in a male. Labia minora, it is homologous to a ventral aspect of penis. Okay. Now, clitoris. Clitoris in a female is homologous to glans. Okay. Glans, penis. In the male. See, clitoris is nothing but an erectile body. It's a erectile organ which can be stimulated especially during the sexual arousal in a female. Okay. Now, Bartholin's gland. Guys, Bartholin's glands are also known as greater vestibular glands. Okay. Now, these Bartholin glands in a female, they are homologous to Cooper glands. Cooper's gland. Okay. Now, how to remember? I used to remember it something like BC. Okay, something like BC AD, right? Okay, 1200 BC, something like that. Okay. So, Bartholin's glands are homologous to Cooper glands and skinny glands. Okay, which are also known as the paraurethral glands. Skein glands are homologous to prostate gland. Prostate. Okay. So, how to remember? SP. Okay. A cadre of police, right? SP, superintendent of police, something like that. Okay. After seeing the homologous structures, now let's discuss about the embryological origin. Means these are the structures and from where they have originated from. Okay. So from an embryo, labia majora, this structure, it have originated from genital swellings. Okay, so the genital swelling, this area, okay, this particular area in the embryo, it's going to develop into labia majora in the female. Labia minora they have developed from genital folds. Okay, clitoris derived from genital tubercle. Okay, now see, this is something important. Vagina, the fibromuscular tube. Now vagina, it was divided into upper one third, middle one third and lower one third. Now the upper one third and middle one third, which I can call as upper two thirds. Okay, the upper two third means the upper one third, middle one third together. The upper part of vagina, it have taken its origin from Mullerian ducts. Mullerian ducts. And the lower one third of the vagina is derived from urogenital swelling. Okay, now what about the vestibule, the triangular area? Now it was also derived from urogenital swellings. Now what about the main organs, main internal reproductive organs of the female? That's the uterus, fallopian tube and the uterus, fallopian tube, cervix. Mainly these three structures, they have derived from again Mullerian ducts. Okay, now what about the ovaries? See, this is something very important. Why, I will say later. Ovaries, they are derived from genital ridge. Okay, why this is important? Now let's discuss, guys. For example, let's take a clinical question. Okay, clinical scenario where a female have no Mullerian ducts. I can say Mullerian agenesis happened in this female. So whenever there is Mullerian agenesis, do you think uterus is going to be present in that female? No, there is no uterus, there is no cervix, there is no fallopian tubes. Why? Because see, uterus, cervix, fallopian tubes, they are derived from a Mullerian ducts. We have already seen. Now they will ask you, there is a female who present to your clinic with the complaints of amenorrhea, so infertility, whatever. Now in her, do you expect ovaries will be present or not? Absolutely present. So a female with Mullerian agenesis, ovaries present or not? Absolutely present. Why? Because ovaries, they are originated from genital ridge but not from the Mullerian duct. So in a Mullerian agenesis female, you are not going to have uterus, you are not going to have the fallopian tubes and a cervix, and also the upper two-third of vagina is not going to be present. Okay, so that is something very important. Now after seeing the embryological derivatives, now let's discuss about the some important points about the Bartholin glands. Okay, not Bartholin glands, like some important points about the structures which are getting open into the vestibule. Now guys, we have already seen that the urethral orifice is getting opened in that area. Please concentrate. Yeah, urethral opening is present, vaginal opening is present, that is the introitus, and ducts of paraurethral gland, something over here present, and ducts of Bartholin glands. Please concentrate. These are the greater vestibular glands, also known as Bartholin glands. So Bartholin gland ducts are also getting opened into this vestibule. Important. So totally how many structures, guys? 6 structures are getting opened into vestibule. Now guys, let's discuss about some important points about Bartholin's gland. Guys, this is a very important point. Here and then they will be asking you one MCQ from this topic. Now Bartholin's gland location, where exactly this Bartholin's gland is located? It is located in a superficial perineal pouch. Okay, it's located in superficial perineal pouch. Now they will be asking you, if this is the Bartholin's gland, definitely there is this acini, this structure, okay, which I am showing you right now. This is the acini of the gland, which is the actual gland part, and this is the duct of the gland. Now what is the question that they are going to ask you is, Bartholin's gland is lined by low columnar epithelium. Okay, low columnar epithelium, or even sometimes the gland can be lined by cuboidal epithelium. Okay. Now, what about the duct of this gland? Bartholin's gland duct is lined by high or multi-layered, multi-layered columnar epithelium. So multi-layered columnar epithelium is present in the duct, and in the acini it is a low columnar or cuboidal epithelium. Now, where exactly, this is something very important. This point need to be repeated. Why? Because this is something very important. Now, where exactly this Bartholin's duct is located? Duct is located in a place where there is a junction of anterior two-third, in the vestibule, anterior two-third and posterior one-third. So in a vestibule, a junction where the anterior two-third and posterior one-third, in this junction, the ducts of Bartholin's gland are getting located. So open set junction between anterior two-third and posterior one-third, in the vestibule. Now, this Bartholin's gland is homologous to, we all know that, BC. The mnemonic which I have said you, BC, Bartholin's gland. This is the Cooper's gland. Cooper's gland. Now, what's the function of this Bartholin's gland? The main function is production of alkaline mucus, during sexual excitement. So this is the function of the Bartholin's gland. Now we have completed the topic of Bartholin's gland. Now let's discuss about the Bartholin cyst. We have completed the Bartholin's gland, normal important points. Now let's talk about certain pathologies which are associated with this Bartholin's gland. Now, what exactly is this Bartholin cyst? Guys, we have discussed that there is this Bartholin's duct, the Bartholin's duct which is opening at the junction of anterior two-third and posterior one-third. We have discussed that. Now, if that duct, if it is getting blocked, now if it's getting blocked, what happens? All the secretions from that Bartholin's gland is not getting drained. So what happens? There will be formation of a cyst. So that's how a Bartholin cyst is going to form. Now, where exactly this cyst is going to present? Guys, please remember, just by looking at the location of this cyst, you can say whether it's a Bartholin cyst or skin gland cyst or some other cyst. So it's very much important to know where exactly this Bartholin cyst is going to present. Now, in this image, please concentrate guys, in this image, the cyst, it is present anteriorly or posteriorly? Just tell me that. It is present posteriorly, definitely it is present posteriorly. Now, where exactly it is located? Is it located laterally or not? Just tell me that. It's more of a lateral, it's not medial, it is more placed towards laterally. So I can say that the location of Bartholin cyst is posterolateral wall. So in which wall of vagina this Bartholin cyst is going to occur? It's a posterolateral wall. Now, Bartholin cyst presentation. If a female is having this Bartholin cyst, how she is going to present? What are the clinical features? Does she is going to have any features or not? Now, it is a painless. This is very important. It's a painless intermittent mass. Why I am saying painless intermittent mass? Means sometimes the cyst will be there, automatically it will be resolved, and again it's going to appear, especially it's going to cause pain during the intercourse. So it is intermittent cyst, especially if at all there is a pain that will be aggravated by the intercourse. Now after that, see, this is the area where more likely you can have a MCQ. See, there is a female and now she is having this Bartholin cyst in the posterolateral wall. Well and good. How you have to treat this condition? Now treatment depends on whether it's a young female or elderly female? If it's a young female, that too, is it a symptomatic cyst or asymptomatic cyst? Now let's go one by one. Now let's imagine that the cyst is asymptomatic. It's a painless, there is no symptoms at all. Asymptomatic, that too, it's occurring in a young female. Now in a young female, this is okay, common, nothing much to do, okay. So there is no treatment required. Now same asymptomatic cyst in a elderly female. If it is a elder female, now what you have to do? Excision. Why we are doing excision? Why? Because there is a risk that this cyst may turn into cancer. So that's the reason why we are doing excision. Now let's talk about symptomatic cyst. If it is a symptomatic cyst, either in a younger female or elderly female, what we can do is marsupialization. So what exactly is this marsupialization? Marsupialization means you are going to give an incision, you are going to drain all that contents, and you are going to exteriorize the cyst. Means you are exposing the cyst towards outside, and these lateral walls of the cyst, okay, these lateral walls are sutured to the surrounding structures. So what you have done? You have opened or exposed the cyst so that it won't reoccur. So marsupialization is a treatment option in a symptomatic cyst. Now after this, let's talk about the Bartholin's abscess. Now if this cyst becomes infested with some microorganisms, okay, this Bartholin's gland cyst, now it is totally contaminated with the microorganisms. Now we are going to call it as abscess. Okay, abscess is nothing but the infection. Now what's the most common organism, guys? It is the E. coli, MCQ. So the organism which is causing the Bartholin's abscess most commonly is the E. coli, and next we can have gonococci and chlamydia and so on. Now Bartholin's gland abscess, if it is a Bartholin's gland abscess, what is the treatment option? If it is an abscess, it is incision and drainage, and the point which needs to be worth noting is Bartholin's gland cyst, posterolateral wall. If it is Gartner cyst, okay, which we are going to discuss later, but Gartner cyst, where it is going to present? It is going to occur in the anterolateral wall of the vagina, okay, important. Now, but if someone asks you, what is the most common cyst? Most common cyst of the vagina, then its answer is the inclusion cyst, okay, inclusion cyst is the most common cyst. This Bartholin cyst, posterolateral wall, Gartner cyst, anterolateral wall, okay, important points. Now after this, let's talk some important points about the Bartholin's cancer. Guys, I have said in elderly females that there is a risk of conversion of this Bartholin's swelling or the Bartholin's cyst into cancer. That's the reason why we are doing excision. In the previous slide we have discussed. Now if someone asks you, Bartholin's cancer is most commonly seen in, yes, there is a risk in the elderly female, that is postmenopausal women. So in a postmenopausal woman, there is a risk of this Bartholin's cancer. So a swelling of the Bartholin's gland, you cannot simply just leave it out just like that. Why? Because swelling of the Bartholin's gland, you have to think it as a cancer until unless proved otherwise. In a elderly female, I am repeating, swelling of the Bartholin's gland is to be considered the Bartholin's cancer until unless proved otherwise. So elderly females are at a risk of getting this Bartholin's cancer. Now what is the most common symptom? The most common symptom, if you are having a mass in the area of vulva, definitely it's a vulvar mass is going to be a scene. That's the most common symptom, okay. Other than that, she can have dyspareunia, a pain during intercourse. And what's the most common type of cancer? Is it adenocarcinoma or squamous carcinoma? It's very basic, right? It's a gland. Bartholin's gland. If it is a gland, definitely it is adenocarcinoma. Adeno means nothing but the gland. So the most common variant or the variety is the adenocarcinoma than a squamous cell carcinoma. Now, what's the criteria for the classification? See, these are just single liners like MCQs, like Honan's criteria. Honan's criteria is used for the classification. And what's the management? The management is a radical vulvectomy, okay, plus bilateral growing and lymph node dissection. Why? Because the cancer is going to spread to those lymph nodes. So you are removing the growing lymph nodes and pelvic lymph nodes along with doing radical vulvectomy. Okay, so these are some important points about the Bartholin's cancer. Now after that, let's see the blood supply of the vulva, nerve supply of the vulva and lymphatic drainage of the vulva. Guys, what we are discussing so far, we are discussing the points about the external genital organs. Now we are going to discuss about the blood supply, nerve supply and lymphatic supply. Now the points need to be noted is vulva is also known as pudendum. Vulva also known as pudendum. So the blood vessel which is supplying pudendum is nothing but pudendal artery. So pudendal artery, that too internal pudendal artery. Now the nerve which is supplying the area of pudendum or vulva is nothing but the pudendal nerve. But important point to be noted here is the root value. They will ask you, what is the root value of the pudendal nerve? S2, S3 and S4. Important MC. Now after that, what is the lymphatic drainage? Lymphatic drainage is very much simple. That area which is nothing but the inguinal region, right? So here the lymphatic drainage from the vulva is going to inguinal lymph nodes. Which inguinal lymph nodes? Superficial inguinal lymph nodes. From there into the deep inguinal lymph nodes. So these are very important points which need to be noted regarding the external genital organs or the vulva. But one important worth mentioning point is, guys, we have discussed about the clitoris, right? Clitoris, that erectile body in the female which is going to be aroused, like which is going to be erected especially during the sexual excitement in a female. Now this clitoris have certain parts like crus, glands and prepuce. Now the glands of the clitoris I am talking, okay, the glands of the clitoris, it's going to drain into a special group of lymph nodes known as lymph nodes of Rosen-Muller or lymph nodes of Cloquet. Guys, please concentrate this point. The glands of the clitoris is going to drain into which lymph nodes? See, this is the MCQ, lymph nodes of Cloquet or Rosen-Muller lymph nodes. Okay, now after seeing this, let's talk about vagina. Okay, now we are going into the internal reproductive organs. So external reproductive organs are completed. Now let's talk about the vagina. Now guys, now vagina, what exactly it is? It is a fibromuscular tube, okay, where the intercourse will happen. Okay, it's a fibromuscular tube. Now if it's a fibromuscular tube, it should have an anterior wall, it should have a posterior wall and the lateral walls. The important point to be noted here for the exam is, please concentrate here. See, this is the anterior wall. Okay, I hope you can see this image, okay, which I am not like coming over the image. See, the image which I am like, the wall which I am highlighting right now, it's the anterior wall, and the wall which is present back to it is a posterior wall. Now just by looking at it, okay, you can say that posterior wall is longer. Okay, the posterior wall, it's much longer when compared to the anterior wall. So that's what I have written here. The posterior wall is 9 centimeters in length and anterior wall is 7.5 centimeters in length. So which I can say that the posterior wall of the vagina is the longest wall. Okay, now well and good. Now after that, let's talk some important points about the fornices. What exactly are these fornices? See, you all know this part which I am showing you right now. Okay, this part is nothing but the cervix. Okay, am I right or not? Okay, let me take some other color so that it will be easy for you now. So this part is nothing but the cervix. So because of the cervix which is entering into the vagina, okay, so as cervix enters into the vagina, it creates certain pockets. Okay, for example, see here. So this pocket, so this is one pocket, and even posteriorly you can see one more pocket. Okay, let me clean it up so that it will be clear for you. Yeah, see. So you are having a pocket over here, and posteriorly also there is a one more pocket. So these pockets, because of the protrusion of cervix into vagina, these pockets are known as fornices. And how many fornices will be there? There will be anterior fornix, posterior fornix and 2 lateral fornices will be there. What are the important points? Guys, important points are with the posterior fornix. See, posterior fornix, it is the deepest fornix. Just by looking at it, you can say that the posterior fornix is the deepest fornix and anterior fornix is the shallowest and posterior fornix is the deepest fornix. Okay, well and good. Now this posterior fornix, especially it is used for chaldosynthesis. So chaldosynthesis is preferably done. Okay, so chaldosynthesis is preferably done in the posterior fornix and posterior fornix is the deepest fornix. Okay, well and good. Now let's talk some important points about the lateral fornices. Now this lateral fornices, okay, in the lateral parts. Now here You can feel even the sensations of the uterine artery, especially during the pregnancy. So these lateral fornices are related to, so close to the lateral fornices, okay, close to the lateral fornices, which structures are present? The uterine artery, ureter and transverse ligament are the cardinal ligament. Very important. Lateral fornices are related to which structures? Ureter, true. Uterine artery, true. And transverse are cardinal ligament, true. Now, guys, what about the peritoneal covering of the vagina? Okay, so this fibromuscular tube, is it covered by any peritoneal or serosal lining? No, the answer is no. Vagina, it's not covered by peritoneal lining, it's not covered. But what is the exception? The exception is near the cul-de-sac. So what exactly is this cul-de-sac? It is also known as pouch of Douglas. Guys, please concentrate. That posteriorly, which structure is present? For example, the structure which I am like showing you right now here, for example, imagine that it's a rectum. Okay, see, imagine that this is the rectum. Okay, well and good. Now, rectum, does it have a peritoneal covering? Yes, absolutely true. So, let me take blue color. See, this is the peritoneal covering of the rectum. The peritoneal covering is coming something like this, and now the peritoneal covering is folding onto the uterus. Okay, peritoneal covering is something coming like this. Okay, well and good. Now, this peritoneal covering, it's forming a pouch posterior to the uterus. This pouch is known as the pouch of Douglas, also known as the cul-de-sac. Well and good. Now, cul-de-sac is nothing but a fold of peritoneum, and this cul-de-sac is lying in the posterior upper one-third of the vagina. This is very, very important. So, posterior upper one-third of the vagina. Okay, posterior wall, upper one-third. See, this is the posterior wall. Let me write it here. Posterior wall, upper one-third. Okay, near cul-de-sac is covered with the peritoneal lining, but the other parts of the vagina, they are not covered with the peritoneal lining. Okay, so this is something important. Now, after this, let's see what is the lining of the vagina and what are the different types of cells which are present in the vagina, and let's talk about the pH of the vagina. Okay, now let's continue. Guys, what is the epithelial lining of the vagina? The epithelial lining of the vagina is stratified, squamous, non-keratinized epithelium. Okay, keratinized is present in the skin. So, stratified squamous, non-keratinized epithelium, which is especially resistant to gonococcal infections. Okay, so they will ask you, squamous epithelium is resistant to which infections? Gonococcal infections. But important point is, in a newborn vagina, okay, in the newborn vagina, the epithelial lining is a transitional epithelium. Okay, now, okay, well and good. Now, in the vagina, it's a polymicrobial environment. There are many bacteria, but the main important inhabitant bacteria in the vagina is a lactobacilli, which is nothing but the Doderleins bacteria. What is this important? See, this Doderleins bacteria, physiologically it is present in the vagina. It's a good bacteria. What it is doing? It is converting the glycogen in the cells. It is converting the glycogen to the lactic acid. Is it good? Presence of lactic acid in the vagina, acidic environment in the vagina. Is it going to be good? Yes, it's absolutely good. Why? Because this acidic environment will prevent the growth of bad bacteria. So, if someone asks you what is the organism which is present in the vagina, it is nothing but the lactobacilli, Doderleins bacilli. What it is doing? Converting glycogen into lactic acid. So, vaginal pH will become acidic. Now, guys, during different time periods in a female, the vaginal pH will also change. Now, let's see during which period the vaginal pH will be acidic and in which time it will be basic. Guys, let's talk about the birth. At birth, vaginal pH in a newborn, okay, in a newborn, let me write it here, in a newborn female, the vaginal pH is acidic. Why it is acidic? It is acidic because the estrogens from the mother are going to enter into the newborn. Okay, now this estrogens, very important point is the point which I haven't discussed with you so far. See, to maintain this Doderlein's bacteria, to maintain the vaginal flora, it is very, very important to have the estrogens. Now, after knowing the important point, like estrogen is responsible for the maintenance of vaginal flora. Now, let's continue. See, estrogens from the mother are going to come into the newborn. Okay, well and good. And even some bacteria, Doderlein's bacteria is coming from the mother. Okay, so from the mother, some Doderlein's bacteria is coming into the newborn's vagina. Okay, well and good. So, because of the presence of estrogens and because of the presence of Doderlein's bacteria both, newborn's vagina is having this acidic environment. Why? Because that lactobacilli is converting the glycogen into lactic acid. So, that acidic environment is maintained. But later what happens? After few days, what happens? After few days, the maternal estrogens which are present in the child, okay, the newborn child, they will be disappeared. A newborn kid, okay, that newborn female, she is not going to make the estrogens. Why? Because her ovaries are not yet functional. So, the estrogen levels in a newborn child will be going down. So, whenever there are no estrogens, can she maintain the vaginal flora? No, she cannot maintain the vaginal flora. So, what happens? The acidic environment will be changing into basic environment or less acidic, more towards the alkaline side. So, before puberty means till puberty, till attaining puberty, her vaginal environment will be more alkaline or less acidic. See, 7.5 is almost basic, 7 is the neutral, 7.5 is basic, or 6.5 means which is almost basic, right? Now, so what I am trying to put into your mind is estrogens are very much important to maintain the vaginal flora. No estrogens, there will be alkaline environment in the vagina. Now, see, during puberty, the vaginal pH will become acidic. Why vaginal pH will become acidic? Because puberty, ovaries are now functional, ovaries are making estrogens. Now, with the help of these estrogens, the vaginal flora can be maintained. So, now this vaginal flora, which is nothing but the lactobacilli, now it is producing the lactic acid. Now, this lactic acid will keep the vaginal environment acidic. So that is the reason why puberty it's acidic. Now, during menstruation again it's becoming basic, more towards the basic side. Why? Because we all know that our blood is basic. Our blood is somewhere around 7.4, our blood pH. So, during menstruation, we all know that blood is passing over the walls of vagina. Now, if blood is passing through the vagina, I can say the vaginal pH will become more alkaline or less acidic. So, because of the blood, vaginal pH will become less acidic or more alkaline. During reproductive age, very much active female, sexually active female, ovaries are functional, they are producing the estrogens maintain the vaginal flora, so acidic environment. Now, during pregnancy, lots of estrogens are there, and because of this lots of estrogens, her vaginal flora will be maintained and her vaginal environment will be acidic. Now, let's discuss about the menopause. During menopause, we all know that estrogen levels will be falling down and progesterone levels will be falling down. As there are no estrogens, do you think the vaginal flora will be maintained? No, absolutely not. The vaginal flora cannot be maintained. So, what happens, guys? During menopause, no estrogens, no flora. So, whenever there is no Doderlein's bacteria, automatically it will become basic. So, this is a very, very important area. Okay. So, they will ask you different stages in a female, different pH. Okay. Now, let's discuss about different types of vaginal epithelial cells. Guys, see, in the walls of vagina, we all know that there are these vaginal epithelial cells. Now, how many different types of vaginal epithelial cells are there? Now, if you can see these blue color cells, which are known as the parabasal cells, means towards the basement membrane. Parabasal cells will be there, intermediary cells will be there, and superficial cells will be there. Okay, there are three different types of cells. Now, please concentrate. Superficial, which are more like superficial in nature, towards the lumen of the vagina. Intermediate cells and basal are parabasal cells. Now, see, during certain stages, there will be more superficial cells, and during certain times or certain stages, there will be more intermediary cells, and during certain states there will be more basal or parabasal cells. Now you should know during which stages which cells will be more in dominance. For example, please concentrate, superficial cells will be more in number, especially during estrogen predominance. Means in a female body, whenever there are good amount of estrogen, whenever there is a good number of estrogens in the body, during that state superficial cells will be more in number. Now my question is, during which phase of menstrual cycle there will be more estrogens in the female body? During follicular phase. We all know that during follicular phase follicles are growing and they are making the estrogens, and because of this estrogens there will be more amount of superficial cells, and intermediary cells will be more in number during a progesterone predominance. And my question is, during which phase of menstrual cycle there will be more amount of progesterone? Progesterone is making by the corpus luteum. So during luteal phase, okay, during luteal phase of menstrual cycle, the corpus luteum is making more amount of progesterone, and this progesterone, under this influence of progesterone, there will be more amount of intermediary cells. And during menopause, please concentrate guys, during menopause you are not having any hormone dominance, means estrogens are going to come down, even progesterones are going to come down, both estrogens and progesterones will fall down. Now during this state there will be more amount of basal or parabasal cells. Now why we are discussing this? So just by looking at the histological picture, if someone says you that there are more number of superficial cells. Now if someone is saying that there are more number of superficial cells, you can say that the female is in follicular phase. How? Superficial cells are more in number during estrogen predominance, and estrogen is going to be more in the body during the follicular phase, something like that. Okay, so this is also very important. After this, let's discuss about the secretions in the vagina. Now before that, please tell me, vagina have secretions or not? Yes, absolutely, vagina have lots of secretions. Now the question is, does vagina have any glands or not? No, vagina doesn't have any glands. Okay, please concentrate that vaginal secretions. Vagina does not have any glands. MCQ, point to be repeated. Okay, very important. Vagina does not have any glands, but from where these secretions are coming? These secretions are coming from the endocervix mainly. Okay, so from the cervix these secretions are dropping down into the vagina. Okay, so from endocervix, from the endometrial glands, okay, in the uterus there will be endometrium, right? So from the endometrium the secretions are coming into the vagina, from the cervix secretions are coming into the vagina, and even from the Bartholin's gland. Okay, Bartholin's glands are not present in the vagina. Bartholin's glands are present in the superficial perineal pore. So from different places all these secretions are gathering in the one place, that's the vagina. But vagina does not have any glands. Now important point is, usually the cervical secretions are alkaline in nature, but vaginal environment is acidic in nature. So vaginal secretions are also acidic. Why? How come a cervical secretion which is alkaline in nature, how it is becoming acidic in nature? See, vaginal secretion is acidic in nature, but the secretions from the cervix are alkaline in nature. How? Very simple, we all know that. From the cervix, see, from the cervix, the secretions whatever are coming, okay, see, this is the vagina, this is vagina, this is the cervix. See, the secretions whatever they are coming from the cervix, they are alkaline in nature, there is no doubt. But once these secretions they are reaching the vagina, in the vagina we know that there is this lactobacilli, and this lactobacilli is producing the lactic acid. This lactic acid is going to mix with these secretions. So now these secretions are going to turn into acidic in nature in the vagina. So that's why vaginal secretions are acidic in nature, but the cervical secretions are alkaline in nature. Okay, now after this let's see some important points, very important points about the angle of anteversion and angle of anteflexion. Okay, see, this topic needs to be discussed under uterus, but in order to give you a better idea, I am discussing this in the topic of vagina. Now we all know that, see, there is this vagina over which there is cervix, uterus. We all know that vagina, cervix, uterus are present. But important point to be noted is, see, they are not lying simply in a longitudinal line. They are not simply lying one over the other. They are not lying in a simple plane, one directional plane. They are more of angulated. What I am trying to say, please concentrate on this image. Guys, please concentrate that. See, the vagina, okay, this one, okay, this fibromuscular tube, this vagina and the cervix, okay. Now, to make the concept more clear, let me explain something like this. The blue color line which I am showing you here, the blue color line is the axis of the vagina, okay. The blue color line is the axis of the vagina, and this red color line is the axis of the cervix, okay. The long axis of the vagina and the long axis of cervix. If you can see, they are angulated. How much angulated? There is this acute angle of 90 degrees, which means they are not lying in a simple one directional plane. They are not simply lying one over the other. They are more angulated. For example, if this is the vagina, the cervix will be something like this. They are more angulated, almost 90 degrees is there. So that is the angle of anteversion, version for V. So between the angle between vagina, okay, the angle between vagina and cervix, okay, so long axis of cervix. Even now the question is, even the cervix, okay, here, even the cervix and the uterus above, even they are angulated, even they are not lying one over the other, something like this, even they are angulated, more bending. So how much, guys? We all know that this red color line which I am showing you right now here, this red color line is the angle of cervix and this green color line is the angle of uterine body. Now they are angulated. How much? Almost 120 degrees. So what I am trying to put into your mind, I know I am repeating, but this is very, very important. The uterus, cervix and vagina, they are not lying one over the other simply in a one plane. They are more angulated. See, vagina is something like this, cervix is something like this with a 90 degree angle, and even uterus is falling forward. So you can clearly see the fundus of the uterus. The fundus of the uterus is towards the anterior abdominal wall. It's like, no, towards the anterior side. It's not simply like this above. It's not above. It is more angulated and the fundus is towards the anterior abdominal wall. Okay. So that is very much important. Now let's see some important points. So it's the angle between version between vagina and cervix, okay. Anteversion is maintained by, we know that there is angulation between vagina, cervix and uterus, but who is maintaining this angle? Why the uterine fundus is towards the anterior side? This is very, very important because someone is pulling, okay, something is pulling the uterine fundus or uterus anteriorly, so that the uterus is flexed anteriorly. So who is that structure? It's the round ligament, okay. Round ligament, see, it attaches to the uterus, true. See, round ligament attaches to an area known as the cornua. Later I will show you the image, but for now, trust me, there is a ligament known as the round ligament. It is attached to the uterus at an area known as cornua. So round ligament, on one end it is attached to the uterus, and on the other end this round ligament, it is passing through the deep inguinal ring, superficial inguinal ring, and it is coming and attaching over the labia majora, means anteriorly, so that uterus is pulled anteriorly or uterus is flexed anteriorly because of the round ligament. Now let me show you, okay, image. Okay, I will show you the image in the later slides, but for now, round ligament is pulling the uterus anteriorly, okay. Now angle of anteversion is maintained by round ligament. Now where exactly this round ligament is arising? Arising at cornua of uterus, okay, and where it is getting terminated. See, this round ligament, it passes through the superficial inguinal ring, it passes through the deep inguinal ring, and later it's coming and getting terminated over the anterior border of this is very, very important, anterior border of labia majora. Okay, it's an important MCQ. Now, derived from this round ligament, from where this is getting derived, it's derived from gubernaculum. Okay, so round ligament derived from which structure? Gubernaculum. And what is the blood supply of this round ligament? Why? Because all these are the questions which were asked previously. What is the blood supply of the round ligament? It is Samson's artery. Okay, so Samson's artery is the artery which is supplying the blood to the round ligament. And very important point is, guys, please look at this image. Please look at this image. Because of the round ligament, the uterus, it is flexing anteriorly and the fundus is towards the anterior abdominal wall. Now, because of this round ligament, there is this angle of anteversion. Okay, anteverted, uterus is anteverted. Now, if you can see in this image, uterus, it is flexing over onto the bladder. So, uterus is something like this, below which the bladder is there. So, I can say bladder is supporting the uterus. So, uterus is simply lying on the bladder. Now, the moment anteversion is lost, or I can say the uterus is now retroverted. Now, when uterus become retroverted, there is no mechanical support by the bladder. Now, bladder is no longer supporting the uterus. So, what happens? When the uterus is retroverted, now there is no mechanical support. Now, what can happen? This uterus can fall down through the vagina. So, this is known as uterine prolapse. So, retroversion will cause the uterocervical prolapse. Okay, important MCQ. This is the first step. So, the first step in the uterine prolapse is the retroversion. Okay, very important. And we have already discussed that anteflexion. What exactly is the anteflexion, guys? Anteflexion, it's an angle between, see here, this one, it's the angle between long axis of the cervix and long axis of the uterus. It will be somewhere around 120 degrees we have discussed. Now, important point is, see, this anteflexion of 120 degrees, where exactly it is happening? It's happening at the level of internal os. Okay, now let me show you. Okay, yeah, see, we know this is the external os of the cervix and there will be internal os of the cervix. Okay, there will be external os, internal os. This anteflexion, this bending is happening at the level of, see, this bending is happening at the level of internal os. Okay, we have completed the topic of vagina also. Now, let's discuss about the uterus. Now, see, in uterus, how many parts are there, guys? Uterus was divided into fundus. So, this part is known as fundus and this part is the body of the uterus, and there will be area, okay, there will be an area known as isthmus. Okay, we'll discuss in detail about the isthmus, where exactly it is located, what are the anatomical landmarks for the isthmus. Now, there is area known as cervix. Okay, so these are the parts of the uterus: fundus, body, isthmus and cervix. Now, what exactly this region known as the cornua? Okay, so what exactly is this and where it is present? Guys, the area where the area where fallopian tubes are getting attached to the uterus. Okay, this area where the fallopian tubes are attaching to the uterus, that area is known as the cornua. Okay, well and good. Now, what are the structures which are attaching to this area of cornua? See, it's not only the fallopian tubes, but there are also certain structures which are getting attached to the area of cornua. Which structures? Now, we already know that one structure is the fallopian tubes. Fallopian tubes are attached. Okay, fallopian tubes. What is the second structure? It's the ovarian ligament. And the third structure which is getting attached to the area of cornua is the round ligament. Okay, What is the important point about the round ligament, guys? The round ligament causes the anteversion and anteflexion, and because of this anteversion and anteflexion, uterus is not getting prolapsed. Once the uterus becomes retroverted, it becomes prolapsed. Okay. Now, guys, now we already know that in the area of cornua, fallopian tubes, ovarian ligament and round ligament, they are getting attached. Okay, well and good. But they will ask you the order. Anterior to posteriorly. Okay, please concentrate in this slide that from anterior to posteriorly, the structures which are attached, they are in the order of RTO. The mnemonic is RTO, Road Transport Officer, right? Okay, something like RTO. So, R for round ligament, T for tubes, our fallopian tubes, and ovarian ligament. For example, this is the area of cornua. Okay, this my, like, you know, my palm is the uterus, for example. See, to the uterus, these three structures are getting attached. Now, what are these three structures, guys? From anterior to posterior, it is RTO. So, anteriorly will be round ligament, middle will be the fallopian tubes, and posteriorly it is ovarian ligament. So, anterior to posterior. Guys, if you can see, I am making this fallopian tube, the middle one, a bit higher. Why? Because if you ask me the structures which are getting attached to the cornua from superior to inferior, okay, from superior to inferior, the superior most structure is the fallopian tube, below which at the same level there will be round ligament and ovarian ligament. Round ligament anteriorly, ovarian ligament posteriorly at the same level, okay, at the same level, but superiorly there will be a fallopian tube. See, why it is important? Why? Because you have to know whether the structure which you are ligating during the sterilization procedure, okay, a female, she want to become like sterile, okay, she want to have a permanent contraception. Now she is going for the tubectomy. So during tubal ligation, you have to know whether you are ligating a fallopian tube or whether you are ligating a round ligament. Now, to identify a proper structure during tubal ligation, you have to know where exactly the tubes are located. So, anterior to posterior, the tubes are located or sandwiched between the round ligament and ovarian ligament. From superior to inferior, the tubes are lying superiorly, and below which the round ligament and ovarian ligament, they are lying at the same level. Now, why it is important? Because identification of a wrong structure is the most common cause of sterilization failure. Most of the time, the doctor who is doing the surgery, they will ligate either the ovarian ligament or a round ligament. Okay, say if they ligate a round ligament or ovarian ligament, then sterilization cannot happen. She will become the pregnant. Okay, so this is very, very important to know where exactly the fallopian tubes are located. Now, after this, let's see some direct single liner kind of questions. Now, what is the shape of the uterus? Uterus is pear shaped, pear shaped or pyriform, okay, pear fruit, right, pear shaped. Now, what is the weight of the non-pregnant uterus? In a non-pregnant uterus, it will weigh somewhere around 50 to 70 grams, and a pregnant uterus can weigh up to 1000 grams. That's almost 1 kilo. Okay. Now, what is the length of the uterus? In a non-pregnant state, the length of the uterus will be a 7.5 centimeters in length, very small, and during pregnancy, it will become 35 centimeters in length. Okay. Now, what is the volume? See, in a non-pregnant state, the volume is very, very less. It's just 10 ml. Okay. It's very less. It's only 10 ml. But during pregnant state, it will become 5000 ml, almost 5 liters. Okay. So, the capacity or the volume of the uterus increases during the pregnancy, almost 5 liters. Okay. Now, after this, let's discuss about the body of the uterus. Now, we are going to discuss about the body of the uterus, isthmus, cervix, something like that. Now, the body of the uterus, we are having the 3 layers. What are these 3 layers, guys? Inside, innermost layer is the endometrium. We all know that innermost layer, this layer, okay, the innermost layer is the endometrium. After that, the middle layer is a muscular layer. It's a myometrium. and outer side we are having this perimetrium, the serosa. Endometrium, myometrium and the perimetrium. These three layers are the present in the body of the uterus. Now, the middle layer is the myometrium. Okay, well and good. But important point is this myometrium, this muscular layer, these muscles, they are arranged in again three layers. These muscles, they are again grouped into three layers. What are they? Outer longitudinal layer, outermost longitudinal layer, and there is a middle crisscross layer and inner circular layer. Why it is important? See, this myometrium, I am talking still about the myometrium. These muscles, they are again grouped into three layers. What are they? Outer longitudinal, middle crisscross layer and inner circular layer. Now, outer perimetrium is there. Endometrium, myometrium, perimetrium. Endometrium, again three layers. Okay. But important point is this middle crisscross layer of the myometrium. See this one. Middle crisscross layer of myometrium. Why it is important? What does it mean by crisscross? Crisscross, interlaced. The muscle fibers, they are interlaced, something like this. Okay. Now, if the muscle layers, for example, please concentrate, if they are crisscrossing each other, if they are intersecting each other, something like this, what happens? If they contract, these spaces will become obliterate. Whatever the spaces which are present over here, they will obliterate. In these spaces, what will be there? Blood vessels will be passing. Okay. So, here are the blood vessels. Okay. Here are the blood vessels. Now, if this layer, okay, this middle crisscross layer, if it contracts, okay, something like this. If it contracts, what happens, guys? The blood vessels which are passing through these spaces, they will be completely obliterated or they will be completely ligated. So, what happens? Bleeding will stop. When bleeding will stop? After delivery. So, after delivery, whatever the bleeding is there, that should be stopped. Otherwise, she will go into postpartum hemorrhage. She will go into shock. Now, to decrease the bleeding after delivery, the uterus is contracting, especially this crisscross layer, it will contract and it will close or it will obliterate all these bleeding blood vessels. So, bleeding will decrease. So, this layer is known as living ligature. Important MCQ. So, which layer of uterus is known as living ligature? In the myometrium, middle crisscross layer is known as living ligature. Why? Because it decreases bleeding after delivery of the baby. Okay. So, it will clamp down, this layer will clamp down the bleeding blood vessels after delivery. So, that's why it is known as living ligature. It will ligate the blood vessels, bleeding blood vessels. Okay. Now, after this, let's discuss some points about the endometrium. Okay. Myometrium, important points completed. Now, let's discuss about the endometrium. What exactly is this endometrium? Innermost lining of the uterus. It is lined by, okay. So, which type of epithelium? This endometrium is made up of which type of epithelium? It is a low columnar epithelium. Already we have discussed that the innermost lining of the uterus or the uterine cavity, it is lined by low columnar epithelium, okay, which is nothing but our endometrium. Now, this endometrium or these epithelial cells, they are arranged in two layers. What are they? Superficial layer means towards the lumen. Okay, let me show you here. See, this is the uterus. Okay. See, this is the uterus. Here, this endometrial cells, for example, this blue one is the basal layer of the endometrium. This blue lining is the basal layer of the endometrium. Over the basal layer, there is this superficial layer of the endometrium. So, endometrium, it is having two layers, superficial layer and basal layer. Now, what are the important points which need to be known? Guys, important points are, this superficial layer, during every month, it will shed out. That's nothing but the menstruation. So, during menstruation, the superficial layer will shed out. If superficial layer is shedding out, there should be superficial layer shed out for the next cycle, right? Yes. So, who produces again this superficial layer? It is the basal layer. Very, very important. This basal layer is acting as a stem cell layer. It will regenerate the superficial endometrium. So, again superficial endometrium was recreated and it will be shedding out next month. So, two layers. What are they? Superficial endometrium, basal endometrium. Superficial layer sheds out every month during menstruation, and basal layer will create again the superficial endometrium. Now, the point need to be noted is basal layer can be damaged due to vigorous curettage. Very, very important point. During menstruation, does basal layer is going to shed out? No. Basal layer will be intact. But if there is vigorous curettage, because of whatever might be the reason, the female is now undergoing curettage. Okay. Now with the curate, the doctor is doing the curettage. Now if the doctor who is doing this, if they are not experienced enough, they might take out this basal endometrium also. If basal endometrium is taken out, if it is lost, means does superficial endometrium is going to recreate again? Is it going to regenerate again? No. Basal endometrium, stem cell layer gone. So now what happens? Now because of this, there will be development of intrauterine adhesions. There will be development of intrauterine synechiae. There will be too much formation of the adhesions inside the uterine cavity. So much amount of adhesions because of the inflammation. You have done too much curettage, that causes lots of inflammatory conditions. Because of the inflammatory conditions, there is formation of the adhesions. For example, all these, for example, see, these are the intrauterine synechiae. Okay. So this is known as Asherman syndrome. So what exactly is Asherman syndrome, guys? Asherman syndrome is a condition where there is development of intrauterine adhesions. Okay, because of a vigorous curettage. Okay, where the basal endometrium is damaged. Okay, well and good. Now we have completed the endometrium also. Now let's talk some important points about the ligaments. Okay, the ligamentous supports of the uterus. Guys, just tell me one point. Does round ligament supports uterus or not? Yes, absolutely, round ligament supports the uterus. There is no doubt that round ligament will support the uterus by making the uterus anteverted and anteflexed. True. Now, there are certain other ligaments known as pubocervical ligaments, cardinal ligaments and uterosacral ligaments. See, these are more important ligaments than the round ligaments. These three ligaments together called as tri-radiate ligaments. Okay, so these are the tri-radiate ligaments, the pubocervical, cardinal ligaments and uterosacral ligaments. See, in this image, you can see these ligaments which are coming posteriorly, okay, and attaching to the uterus. These are the uterosacral ligaments. See, on one side they are getting attached to the sacrum, and on the other side they are attaching to the uterus. So these are the uterosacral ligaments. Okay, well and good. Now, where exactly are these cardinal ligaments present? See, these fan-shaped ligaments, okay, which are coming from the sideways, these fan-shaped ligaments. So these ligaments, which I am highlighting in blue color, they are the cardinal ligaments, which are very, very important ligaments. Out of all the ligaments, these cardinal ligaments are very, very important. These cardinal ligaments are also known as the transverse cervical ligaments or McEnroth's ligaments. Out of all the ligamentous supports, the one ligament which is very, very important is the cardinal ligament. Okay. Now, so where exactly is this pubocervical ligament is present? We have seen the uterosacral. Okay, the uterosacral ligament is completed. That's a posteriorly present ligament. Cardinal ligament, which is present transversely, which is also known as the transverse cervical ligament. So where exactly is this a pubocervical ligament is present? On one side pubis, other side cervix. So these ligaments, okay, which are coming something like this. These are the pubocervical ligaments. Okay, let me take some other color. Okay, these green color ligaments. Okay, pubo means anteriorly towards the pubis. Okay, anteriorly towards the pubis and posteriorly towards the cervix. So pubocervical ligaments means from three directions: pubocervical anteriorly, uterosacral posteriorly, and from sideways it's a transverse cervical or cardinal ligaments. So from three sides, tri-radiate ligaments are keeping the uterus in its place. Okay, so they are the supports for the uterus. Okay, well and good. Now, guys, can you show the round ligaments in this image? Can you see the round ligaments? Yes, see these ligaments which I am now highlighting in the red color, these ligaments, if you can see these ligaments which are coming like this, okay, these ligaments coming anteriorly on one side, they are attaching to the cornua of the uterus, and the other side they are moving anteriorly. They are nothing but our round ligaments. In this image you can clearly see they are flexing the uterus towards the anterior side, so that the fundus become more towards the anterior side. Now the uterus is flexing onto the bladder. Okay, so this causes the mechanical support, or this causes the anteversion and creates the mechanical support for the uterus by placing the uterus over the bladder. Okay, and even in this image, in this cross section, see this is the uterus. Yeah, this is the uterus. Now you can, this is the bladder. Okay, this is the posterior abdominal wall. Why? Because see, you can see the sacrum over here. This is the vertebrae, and these are these green color ligaments. Okay, these green color ligaments, see here also, these green color ligaments are our round ligaments. See, they are moving towards the anterior abdominal wall, and where they will terminate, guys, they will terminate anteriorly in the labia majora. Okay, making the uterus fall onto the bladder, creating a mechanical support. Okay, now so pubocervical ligament, cardinal ligament, uterosacral ligament, and round ligament. All these ligaments are the supports for the uterus. Main supports are the triradiate ligament. Main supports, triradiate. Even within the triradiate ligaments, cardinal ligaments are the main supports. Round ligament, is it a support or not? Yes, it's a support, but not the main support. It's a secondary support. Round ligament, it's a secondary support. Now, broad ligament, is it a support at all? No, broad ligament is not a support of the uterus. Okay, we all know this broad ligament, right? See, this, the structure which you are seeing over here, this is a peritoneal covering. Okay, double folded peritoneum. Broad ligament is not a support at all. So broad ligament, it's under the non-supports. Secondary support is the round ligament. Primary supports are the pubocervical anteriorly, uterosacral posteriorly, and cardinal ligaments transversely. Cardinal ligaments are also known as transverse cervical ligaments or McEnroth's ligament, which is a very important ligament. I know I am repeating, but these are the questions need to be repeated. Okay, very important questions. Now, after this, let's talk about the contents of the broad ligament. We have discussed that broad ligaments are not the supports at all. So what are the structures which are present inside this broad ligament? The structures, the mnemonic which I found for myself is the bro peg. Bro, let's have a peg, something like that. Okay, bro peg. So B for blood vessels are present. Which blood vessels? Blood vessels of the uterus, blood vessels of the cervix, blood vessels of the ovaries. So blood vessels are present. R for round ligaments, very important point. Round ligaments, they are present inside the broad ligament. Ovarian ligament present inside the broad ligament. And PEG, peg for, see these peg structures, PEG, these are the vestigial structures. Okay, see they are nothing but the remnants of Wolffian duct inside a female. Okay, even females have this Wolffian duct. Actually, Wolffian duct forms the male reproductive organs, right? Wolffian duct is also present in a female embryo, but that will be regressed. Female embryo doesn't have testosterone. So the Wolffian duct, because of no presence of testosterone, it will be regressed. And now this Wolffian duct, it becomes paraphoron, epophoron, and Gartner's duct, and these three vestigial structures, they are present inside the broad ligament. So they will ask you, all of the following are the structures which are present inside the broad ligament except. So that kind of questions you might be asked. Ovaries, are they part of broad ligament? No, they are not a part of broad ligament. Okay, something like that. Only these structures are part of broad ligament. Okay, now after this, let's talk about the blood supply of the uterus. Very important topic. Guys, I think almost 5 times maybe or even 10 times this question was asked. Blood supply of the uterus is simple, uterine artery, but that's not the question. Uterine artery is a branch of, uterine artery, it's a branch of anterior division of internal iliac artery. This is the MCQ. Okay, see this is the uterine artery. Uterine artery. Now uterine artery, now it is going inside the uterus, it is going into the uterus. So it have to cross perimetrium, myometrium, and have to enter the endometrium. So now you can see this A is nothing but the arcuate artery, which means the uterine artery is further dividing. There are certain branches for the uterine artery. So now let's see what are the branches of the uterine artery. The branches of the uterine artery, the mnemonic is ARBS, A-R-B-S, ARBS. It is a arcuate artery, this arc, okay, this arc kind of thing. This is the arcuate artery. After arcuate artery, there are these radial arteries, straight branches, radial arteries, arcuate, radial, and basal arteries. See this basal, the small branches, these are the basal arteries. And you can see these arteries which are spiraling around, these spiralings, these are the spiral arteries. What they will ask you is, they won't ask you what are the branches of the uterine artery. They will ask you which branch supply which area. Okay, for example, A. These arcuate arteries, they are more outside the uterus, they are more outside. So it will supply, this arcuate arteries supply outer 1/3 of the myometrium, outer parts. Outer 1/3 of the myometrium. Now radial artery, it's becoming more inner. Okay, now these branches are coming more inside the uterus. So radial artery, it supplies inner 2/3 of myometrium. Outer 1/3 is arcuate, inner 2/3 is radial artery. And basal artery, in the name itself it's very clear, basal for basal endometrium. Okay, supplies the basal endometrium, and the spiral arteries supply the superficial endometrium. Okay, this is the MCQ. Superficial endometrium, we all know that endometrium is of two types, right? Superficial, sheds every month, and basal endometrium, which is a regenerating layer. So superficial endometrium, it's getting blood supply from the spiral arteries. Okay, so these are the branches of the uterine artery. And uterine artery, again I am repeating, it's a branch of anterior division of internal iliac artery. Okay, completed. Now after this, let's talk about the lymphatic drainage. Okay, the lymphatic drainage of the uterus. Now the fundus of the uterus, it is draining into para-aortic lymph nodes. I used to remember it something like PES, P-E-S. So P-E-S, fundus, para-aortic lymph nodes. Body, after fundus, we all know that above fundus will be there, body will be there. So para-aortic lymph nodes, E for external iliac lymph nodes, and the cornua, this is important, the cornua of the uterus will drain into superficial inguinal lymph nodes. P-E-S, para-aortic, external iliac lymph nodes, S for superficial inguinal lymph nodes. This is the lymphatic supply. After this, let's talk about the nerve supply of the uterus. Nerve supply is coming from T10 to L1 spinal nerves. Okay, it's a sensory supply. So uterus is getting its sensory innervation from T10 to L1 spinal nerves. Okay, so this is very much important, especially when we are discussing the topic of labor. So if you want to have a painless vaginal delivery, at what segment you have to give the block? You have to give the block till T10. Why? Because uterine contractions will cause the pain. So block should be given from T10, so all the below structures will become blocked. Anyway, this topic will be discussed in the topic of labor. But for now, just remember that uterus is getting its sensory innervation from T10 to L1. Or I can say pain sensations from the uterus will be taken by which spinal nerves? T10 to L1. Okay. Now, after this, let's talk some important concepts. What is this water under the bridge? Okay, so what is this water under the bridge? Water here is nothing but the urine. Okay, so what is this bridge? The bridge which I am talking right here is nothing but the artery. Which artery? Uterine artery. So the relationship between the uterine artery and the ureter which have the urine. So this is known as water under the bridge. So what I am trying to put, guys, ureter, it passes posteriorly to the uterine artery. There is one area where ureter, for example, this is the ureter. Ureter is passing posteriorly. Above there is this uterine artery. So bridge, water. So water under the bridge. So where exactly this area is located? See in this image, please concentrate in this image. So this structure, okay, this grey color structure, this is nothing but the ureter. Now we all know that this is the uterine artery. Okay, this is the uterine artery. So uterine artery is above, posteriorly there is ureter. Now where exactly this structure is located? It is located, see this is the internal os, for example. Here is the internal os located. Here is the internal os located. So 2 centimeters, okay, 2 centimeters lateral from the internal os, the uterine artery passes over the ureter. This is known as water under the bridge. So site is 2 centimeters lateral to the internal cervical os. Okay, so why it is important? Why? Because this is the site for ureteric damage. So this is the most common site where the ureter gets damaged during the surgeries. Okay, so very important point. Now let's see some important points about the internal os. Guys, what exactly is external os? External os is nothing but the opening of cervix into the vagina. Okay, the opening, see this is the external os. I think you can see. Okay, I hope you can see. I am not just simply covering the image. See, this is the external os. Okay, the place where cervix is opening into the vagina. But what is internal os and what are the important points? Guys, see, the internal os, it was further divided into 2 types. What are they? Anatomical os and histological os. What exactly is this anatomical os and what exactly is this histological os? Now let's see. In the name itself, it's very clear. You should understand something like this. Anatomical os means something anatomically relevant. So anatomical os is a place where the wider uterine cavity, it is getting narrower. So something anatomically, broad uterine cavity, it is getting narrower. So anatomically it is getting narrower. So the place where the broad uterine cavity, it is getting narrower. This is known as anatomical os. And what is histological os? Histological os means something histologically relevant, where the low columnar epithelium of the uterus is getting converted into high columnar epithelium of the cervix, which means the place where the low columnar epithelium of the uterus is getting converted into the high columnar epithelium of the endocervix. So this area is known as the histological os. So it's very clear that anatomical os is above. Okay, above is the anatomical os. Okay, and histological os is below. Okay, so histological os is below, anatomical os is above. See why this is important? Why? Because see, in between the anatomical os and in between the histological os, this area is known as isthmus. Okay, this area between anatomical os and histological os is known as isthmus. Important MCQ. So isthmus above, what do we have? Isthmus above we have anatomical os, below what do we have? Histological os. So that's very important. Now after this, there are certain important points about the internal os, certain important clinical points. What are they? See, the clinical importance is at the level of internal os, already we have discussed anti-flexion will happen. Okay, we have already discussed at the topic of anti-flexion. Anti-flexion is happening at the level of internal os, internal cervical os. Okay, well and good. Now the uterine artery moves upward at the level of internal cervical os. See, please concentrate guys. Here is the internal cervical os, for example. So at this place, the uterine artery, you can see the uterine artery is moving upward. Important landmark. Now the peritoneum is reflected onto the bladder. I have already discussed that. For example, this is the uterus. I am showing you lateral view. This is the uterus. Posteriorly there is this rectum. Okay, rectum, it is having the peritoneal lining,
and this peritoneal lining is coming on to the bladder, okay, something like this, and now it creates pouch of Douglas. So the peritoneal lining is folding onto the uterus, okay, onto the uterus, and from the uterus now it's getting reflected onto the, see, anteriorly there is one more structure. What is that? Here is the bladder, okay. Now this peritoneal lining, it is getting reflected over the bladder. Which area? This area, okay, this is the area. So this area, see, this is the level of internal cervical os. See, in this image, please concentrate. It's not very clear, but please try to understand. See, at the level of internal cervical os, this area, the peritoneal lining is falling over the bladder at the level of internal cervical os, okay. Now, uterosacral ligaments lie at this level, at the level of internal cervical os. The uterosacral ligaments, they are coming and attaching. Now let me show you an image so that it will be clear. Guys, please concentrate on this pink color ligaments, okay, this pink color area. These are nothing but the uterosacral ligaments. Now if you can see, the uterosacral ligaments, they are coming and attaching to the cervix. So this segment is nothing but the internal cervical os, okay, internal cervical os. So the uterosacrals, they are coming and attaching to the level of internal cervical os. So these are some clinically important points, okay, clinically relevant points. Now after this, let's talk a few points about the isthmus, okay. Now guys, where exactly this isthmic part of the uterus is located? It is located between anatomical and histological internal os. Anatomical os is above, histological os is below. In between this area is the isthmus. Okay, well and good. Now what is the significance of this isthmus? Why it is important? Why it is relevant for us? Why? Because this isthmus, it forms the lower uterine segment, okay, during pregnancy, during delivery, in order to accommodate the upcoming baby. Okay, the baby will be getting delivered, right? The baby is also growing. In order to accommodate this baby, this small part of isthmus, it's very small area. Actually, it is 0.5 centimeters. Okay, it's just only 0.5 centimeters in a non-pregnant. Now, when she become pregnant, and at the time of term, especially at the time of term, it's almost 5 centimeters. Means it's increased in length in order to accommodate the baby, upcoming baby. So the significance is it forms the lower uterine segment. Even lower uterine segment is formed by the cervix, but 70% of the lower uterine segment is formed by the isthmus. Remaining 30% is formed by the cervix. So important point is lower uterine segment is mainly formed by isthmus. And in a non-pregnant female, it is only 0.5 centimeters. And during term, how much it will become? It becomes almost 5 centimeters. And during delivery, okay, during labor, it becomes 10 centimeters. It is expanding and accommodating the baby. So isthmus is very, very important. Formed the lower uterine segment. Lower uterine segment is formed by the isthmus. Now we have even completed the topic of uterus. Now let's continue with the fallopian tubes and the ovaries. Now before going to discuss about the fallopian tubes and ovaries, now let's see some important points about the cervix. Cervix is mainly made up of the connective tissue. Okay, it's mainly made up of connective tissue, and only 10% of cervix is made up of smooth muscle. And what is the shape of the cervix? It is a cylindrical in nature. It's not cylindrical in nature, it's cylindrical in shape. And what is the length of the cervix? The length is 2.5 centimeters. It's very small, but actually during pregnancy, the length will be increased to 4 centimeters. I have said right, during pregnancy, the cervix will form the lower uterine segment. Okay, isthmus forms the major part of the lower uterine segment, but cervix will also increase in its size and forms the lower uterine segment. Okay, now guys, some important points are, according to the different ages in a female, the uterus to the cervix length will change, or I can say the uterus to the cervical ratio, uterine cervical ratio will change according to different time periods in a female. For example, before puberty, the body to cervix ratio, body is nothing but the uterine body, is somewhere around 1:2. What does I mean by? Cervix is 2 times the length of the uterine body, means cervix is more in length when compared to the uterine body, means before puberty. But once she is into puberty, now she is fertile, right? Now her uterine body length will increase in comparison to the cervix. Now it will become reverse, 2:1. Now the uterine body is more in length when compared to the cervix. Now during childbearing age, now she is able to bear a child. So her uterine cavity, her body of the uterus is much more bigger. Now it will become 3:1. During menopause or during birth, okay, during birth or even a newborn, during menopause or in a newborn child, it will be 1:1. The uterus to cervical length or the uterine body to cervical length is 1:1, which means they are of same length. During menopause, everything will be atrophied. Cervix and uterine body, they are atrophied and they become 1:1. So you can expect an MCQ from here. Now guys, what you are seeing here in these images are nothing but the external cervical os. Now this external cervical os is nothing but the place where the cervix is entering or opening into the vagina, we have already discussed. Now the shape of the external cervical os is important. For example, in a nulliparous female, means she is not a mother. Now she haven't delivered any babies, she is nulliparous. Now she haven't have any vaginal delivery. Now if she is not having any vaginal delivery, her cervical os, external cervical os, will look round in shape. Okay, it will be round in shape. Now if she is a multiparous female, that too she have the vaginal delivery. The moment she have the vaginal delivery, her cervical os will become slit like, okay, transverse in shape, transverse slit, okay, so transverse slit like. So these are some important points need to be known. Now after this, let's see about the cervix. Some important points about the cervix is the ectocervix and endocervix. We all know that cervix is divided into ectocervix and endocervix. See, this ectocervix means the portio vaginalis, also known as the portio vaginalis, which is towards the vagina. For example, here. So this is part of cervix, this part of cervix which is towards the vagina. It is lined by stratified squamous epithelium, and endocervix, which is internal, it's lined by tall columnar epithelium. Why it is important? Why? Because there is a junction where the tall columnar epithelium of endocervix getting converted into the stratified squamous epithelium of the exocervix. So the junction, this junction where the tall columnar epithelium of the endocervix is getting converted into the stratified squamous epithelium of the exocervix, that transitional zone is known as squamocolumnar junction. Okay, so this transitional zone is also known as a squamocolumnar junction. Okay, so that's the place where columnar epithelium of endocervix is getting converted to stratified squamous epithelium of exocervix. What are the important points? See, it's a dynamic point. What does it mean by dynamic point? See, it usually changes according to the age. Okay, during puberty, it will be more outside. After delivery, it will be more outside. As with increasing in age, it internalizes. So this point, it will internalize. So that's what I want you to know. With age, it will change its point. And in this image, you can clearly see that this is the stratified squamous epithelium. It's a stratified squamous epithelium, and these are the tall columnar epithelium. Okay, these are the low columnar epithelium. So this junction is known as squamocolumnar junction or transition zone. So can I say that in this area metaplasia is happening. Yes, absolutely metaplasia is happening. Why? Because one type of epithelium is getting changed into other type of epithelium. So this is a site of physiological metaplasia. Okay, so physiologically metaplasia is happening in the transitional zone. Okay, and this transitional zone or squamocolumnar junction is the most common site for certain pre-malignant and malignant conditions. Like for example, cervical intraepithelial neoplasia, which is a pre-malignant condition of the cervix, and cervical cancer. So this is the most favorable site or the most common site for the cervical cancer transitional zone. After this, where exactly this zone is located? It is located 1.7 centimeters to 2.5 centimeters or 2.3 centimeters from the external os. So from the external os, usually it changes with the time, but from the external os, it is located 1.7 centimeters away. Okay, well, now in this image you can clearly see that this red color area, see this red color area is nothing but the endocervix. Okay, endocervix is usually red in color. Exocervix, see this pink color area, all this pink color area, okay, all this pink color area is the exocervix. This red color area is the endocervix. Pink color area is the exocervix. In between them, there is an area where there is this white color. Okay, this white color area. So this white color area is nothing but the transitional zone. So transitional zone is white in color. It's white in color. Exocervix is pink in color. Okay, so these are some important points which you need to know. Now after this, let's talk about the blood supply of the cervix. Cervix is getting its blood supply from the descending cervical artery, and the nerve supply is from S2, S3, S4 spinal nerves. That's a pudendal nerve. Okay, so S2, S3, S4 spinal nerves is giving the nerve supply, and the blood supply is from the descending cervical artery. Now very important point, the lymphatic supply. Okay, the lymphatic supply of the cervix. There is a mnemonic which is HOPE, H-O-P-E. Okay, so the lymphatic supply is coming from the hypogastric lymph nodes, obturator lymph nodes, paracervical and external iliac lymph nodes. What I mean is the lymphatic drainage is going to these lymph nodes. Okay, so from the cervix, the lymphatic drainage is draining into hypogastric, obturator, paracervical and external iliac lymph nodes. But very important MCQ is, what is the most common lymph node affected in CA cervix? It is the external iliac. Previously in version 1 videos, I have said that obturator lymph nodes are most common lymph nodes which are affected in the CA cervix. But the recent advancements showing that external iliac lymph nodes are the most common lymph nodes which are getting affected in the CA cervix. Very important. Now after this, let's talk about the fallopian tubes. Guys, fallopian tubes, okay, these tubal structures, okay, these tubes, these tubal structures, they are divided into parts. The first part is the interstitial part. Okay, this part is the interstitial part, the part where the fallopian tube is attaching to the uterus, that cornual area. Okay, so this part is the interstitial part, also known as intramural part. Okay, intramural part. Now let's see some important points, guys. See, this interstitial part is the narrowest part. First point is it's a narrowest part. It's the narrowest part. Okay, well and good. It is narrowest anatomically, so it is acting as an anatomical sphincter. Okay, and the cornual end of the fallopian tubes. See, this cornual end of the fallopian tubes, they are blocked by TB. Okay, so TB blocks the cornual end of the fallopian tube. Now, After this, the part which we have here, this part is the isthmus. Now it's the second narrowest part, second narrowest part, and it acts as a physiological sphincter. Okay. Now, in regard with the ectopic pregnancy, we all know that ectopic pregnancy means the pregnancy is happening outside the uterine cavity. Now I am talking about the tubal ectopic, means ectopic pregnancy happening in the tubes. Now in regarding with the tubal ectopic, isthmus is the most common site for the tubal rupture. What does I mean by, if at all there is a tubal ectopic, and that too this ectopic pregnancy is happening in the isthmus area of the fallopian tube. Now if ectopic pregnancy is happening in the isthmus area of the fallopian tube, this area is very narrow, so that this isthmus will easily rupture. So most common site of tubal rupture in tubal ectopic is the isthmus. Okay, and isthmus, there is one more important point, that if you want to ligate, okay, if you want to ligate the tubes, for example, there is a female, now she came to you and she want to have a tubectomy. Now you want to ligate the tubes, you have to give the cut to the tubes. Where exactly you will give? Isthmus. Isthmus is the preferred site. Okay, isthmus is the preferred site to ligate. Okay, so why? Because if you want to re-anastomose in future, she want to have children again. If you want to re-anastomose these tubes again, isthmic re-anastomosis will have a better outcomes. So all time give a cut in the area of isthmus. So a preferred site for tubal ligation is isthmus, and isthmus is the most common site where tubal rupture can happen in the ectopic pregnancy. Okay. Now after this, see this yellow color area of the fallopian tube, this yellow color area of the fallopian tube, this area is nothing but our ampulla. And what are the important points about the ampulla? The important points are, it's the most common site of fertilization. Okay, most common site of fertilization, and ampulla is the widest part. Okay, it is the widest part, and it is the most common site of fertilization, and the ampulla is also most common site for ectopic pregnancy. Okay. Now last important point is, in regarding with the ectopic pregnancy, most common site for a tubal abortion. See, if I am talking about the fate of ectopic pregnancy, there is this tubal ectopic. Either this ectopic pregnancy can undergo rupture, that will happen in the isthmus, or either this tubal ectopic simply undergo abortion, simply it's resolved. So most common site for the tubal abortion is the ampulla, and most common site for the tubal rupture is the isthmus. Okay, these points need to be kept in mind. Now this area which is little light green in color, this funnel shaped area, this is known as infundibulum, and after that you will have these finger like projections. So these are nothing but the fimbriae, or the fimbrial end of the fallopian tube. What is the important point of about the fimbria of the fallopian tube? Why? Because this fimbrial end of the fallopian tube can get blocked by gonococcal infection. Okay, so gonococcal infection can cause block of the fimbrial end of the fallopian tube. Very, very important. TB causes block in the carnival end. Gonococcus causes a block in the fimbrial end. Okay. Now please concentrate on these important points. Very, very important. And one more important point is, they will repeatedly asking this: what is the length of the fallopian tube? The length of the fallopian tube is somewhere around 10 to 12 centimeters. Okay. Very important. 10 to 12 centimeters. One fallopian tube length. Okay. After this, let's see some important cells in the fallopian tube, and what is the lining of this fallopian tube. The lining epithelium is a ciliated columnar epithelium. Why it is a ciliated columnar epithelium? It is having ciliary action or ciliary beating to move the ovum from the fallopian tube into the uterine cavity, or to move the embryo
if the ovum is getting fertilized, to move this fertilized ovum into the uterine cavity, you need to have ciliary action. Okay, so it is a ciliated columnar epithelium, and inside this fallopian tube there are these special cells which are known as PEG cells. They are thought to be secretory and nutritive in function. Okay, we don't know exact function, but they are thought to be secretory and nutritive in function, and they are non-ciliated cells. Okay, they are non-ciliated. They will ask you, non-ciliated columnar cells which are present in the fallopian tubes, which are thought to be secretive and nutritive in function, are known as PEG cells, or they can simply ask PEG cells are present in fallopian tubes. That's it. Now, if I am talking about the blood supply of the fallopian tube, see, medial 2/3 is supplied by uterine artery and lateral 1/3 is supplied by ovarian artery. Okay, let me show you. See, this part is the medial 1/3. Okay, this part, for example, see, sorry, medial 2/3. Let me show you. Yeah, this medial 2/3. See, my question is, this medial 2/3, it is more towards the uterus, right? It's more towards the uterus, attached to the uterus. So, medial 2/3, it is getting its blood supply from uterine artery. The lateral, okay, this part, the lateral part, the lateral 1/3, it's getting its blood supply from the ovarian artery. Okay. So, lateral 1/3 from the ovarian artery and medial 2/3 from the uterine artery. Okay. Now, what about the lymphatic supply? The lymph is draining into para-aortic lymph nodes, but especially from the isthmus of the fallopian tube. From the isthmus, blood, sorry, not blood, it's a lymph. Lymph is going into superficial inguinal lymph nodes, and the nerve supply is from T11, 12 and L1 thoracic spinal nerves. Okay, thoracic and lumbar 1 spinal nerve. So, this is the blood supply, lymphatic drainage and the nerve supply. Now, important point is, see, I have already said you that the ciliary motion is important to move the product of conceptus, or the ciliary beating is important to move embryo from the fallopian tube into the uterine cavity. Okay, but the ciliary beating is not the major action for the movement of the embryo from the fallopian tube into the uterine cavity. It's not the major action by the ciliary beating. There will be peristaltic action of the fallopian tubes. Because of the peristaltic action of the fallopian tubes, the embryo will be moving from the fallopian tubes into the uterine cavity. See, this peristaltic action is the major mechanism by which the embryo is moving from the fallopian tube into the uterine cavity. See, ciliary action will also add up, but that's not the major. Major is peristaltic action by the fallopian tube. Okay, so that's the point which was given here. Okay, ciliary beating towards the uterine cavity is minor, but major is with the peristaltic action. Okay, okay. Now, after fallopian tube, important points. Now, let's talk about the ovaries. Now, ovaries is a very small topic. Now, where exactly the ovaries are located? Ovaries are located in a fossa known as fossa of Walder. Okay, fossa of Walder, there is this fossa where these ovaries are located, and the ovaries are derived from embryological, they are derived from genital ridge. Already we have discussed this. And ovarian attachments. Guys, please concentrate that if this is a uterus, for example, here are the fallopian tubes. Now, our ovary is present somewhere over here. See, ovaries medially, they are attached to the uterus with the help of ovarian ligament. See, this green color structure is the ovarian ligament which is attaching the ovary to the uterus medially. And for example, this structure which I am showing in red color, this structure on one side it is attaching the ovary, on the other side they are attaching to the lateral pelvic wall. So, ovary on one side
it is getting attached to the uterus with the help of ovarian ligament, and on the other side laterally it is getting attached to the lateral pelvic wall with the help of infundibulopelvic ligament. So what are the two ligaments which are suspending the ovary, guys? Ovarian ligament and infundibulopelvic ligament. Okay. Now what is the blood supply? Ovary, ovarian artery, very simple, but important MCQ is ovarian artery. Ovarian artery, it's a branch of abdominal aorta, but uterine artery, it's a branch of anterior division of internal iliac artery. Here ovarian artery is a branch of abdominal aorta. From the abdominal aorta, ovarian artery is taking its origin at the level of L2, and the nerve supply to the ovary is coming from the ovarian plexus, and the lymphatic drainage is going into the para-aortic lymph nodes. Okay, so these are some important points about the ovaries. Okay, now after this, let's talk a few points which are very important. Okay, guys, here and then they will be asking you, already you are expert in this. For example, Bartholin's gland, acini of the Bartholin's gland, it is lined by low columnar epithelium or cuboidal epithelium. Bartholin's duct, it is lined by multi-layered columnar epithelial cells, we have discussed. Adult vagina lined by stratified squamous non-keratinized epithelium. Okay, newborn vagina is lined by transitional epithelium. Guys, important point is stratified squamous non-keratinized epithelium. Okay, now which is resistant to gonococci, which we have already discussed. Uterine cavity lined by low columnar epithelium. Cervix, now here is cervix, endocervix, it is lined by high columnar epithelium, and exocervix, the portio vaginalis towards the vagina, lined by again stratified squamous epithelium. Fallopian tubes are lined by ciliated columnar epithelium, and in fallopian tubes there are cells called as PEG cells, which are non-ciliated cells. Okay, now we have discussed all the important points which are needed for your exams. So the anatomy of female reproductive tract topic is completed. Hope the lecture is helpful. Thank you.